Hi everyone, my name is Michelle Dufresne and I'm going to be lecturing about tissue integrity for you. The state of structurally intact and physiologically functioning epithelial tissue, such as the integument, is what we call tissue integrity. It includes the skin and the mucous membranes and subcutaneous tissue. The underlying layers are also involved with this system, which includes the fascia, muscle, and bone. So tissue integrity can be defined as an integumentary mucous membrane corneal subcutaneous tissue that is uninterrupted. As you look at the PowerPoint slides, you'll see one slide shows you a map of all these layers I just mentioned: the skin, fat, fascia, muscle, and bone, in that order. Fat, fascia, and muscle, once it's damaged, cannot fully regenerate. The fascia, muscle, and bone are the most sensitive layers to ischemia. And remember, ischemia is lack of oxygen or perfusion to tissue or cells. So as we go along, we will look at the functions of the skin now. Just a few facts about the integumentary system. There are 7 layers of cells that make up the skin, and there is about 20 square feet of skin tissue on anybody's body, the average man, that is. 15% of your weight is composed of this skin and tissue. So it's a lot of material to take care of and perfuse. So we need to be aware of its functions now. So basically its function is in protection, body temperature, psychosocial functions, sensation, synthesis of certain vitamins, storage of vitamins and minerals, immunological function, aspiration, and elimination. So if we look at these functions a little bit closer, for protection, the epidermis, of course, you already know, is our first line of defense against the environmental harms out here in the world. So it protects us from microorganisms that may enter our body and cause conditions that are unfavorable. Our skin does have a normal flora that lives on its surface, and without it, we would not have a healthy skin or integrity to our tissue there without that normal flora. Temperature. Its major role in temperature involves the adipose layer of the skin in thermal regulation. So it kind of insulates our body, the fat layer of our skin. Psychosocial, it's that aesthetic appearance of that our skin gives us. It affects your body image, your appearance, your affect, your mood about yourself, your self-concept. Sensation. The skin has many nerve endings within it, and so with that, your senses of touch, pressure, temperature, pain is involved with the skin. For synthesis of vitamins, vitamin D is the major vitamin that's produced within the skin with exposure to the sunlight, ultraviolet light. You need at least 15 minutes of exposure to begin synthesizing vitamin D. Without that, you could develop a deficit in vitamin D. So if you are, like most students, hunkered down inside reading and not getting outside enough, you probably have a deficit in vitamin D. So you probably should take a supplement. And we have many, many patients who would fall into that problem as well. All our bedbound patients who can't get outside easily will definitely have this issue. Immunity. It involves your sensitivity to allergens in the environment. So you would assess for reactions in the skin for that kind of immune response to an allergen. Absorption. Our skin absorbs many things and it plays havoc on us if it's the wrong thing, like toxins, such as plants like poison ivy, poison oak, Indian fire. You could probably come up with a bunch of other things that are not so good. So you would observe for problems like that in the skin as far as absorption. And elimination. The skin is a major organ for the excretion of different debris or results of metabolism through the sweat glands, for example, or sebaceous glands. All right, so those are the functions to keep in mind. There are factors that affect the integumentary system or the integrity of our skin. So a few I'm going to stress here involve genetics, age, and underlying health conditions and nutrition. So with genetics, the main thing about that is it's going to determine the appearance of your skin, the color of your skin, your sensitivity to sunlight, your sensitivity to allergens in the environment, for example. Nutrition. Without proper nutrition, we definitely could not have an intact integument because you need proteins and vitamins and minerals to reproduce cells. And our skin is one of those organs that is constantly replacing itself. Every 28 to 30 days, you should have new skin cells being produced, always. So now let's look at briefly underlying health conditions. There are many things about different chronic conditions that affect our skin. The disease itself will affect how your skin functions, and then the treatments for those diseases or conditions can affect the skin. Example, the use of corticosteroids to treat certain conditions like lung disease, arthritis, those kind of things, cancer even. So one last thing I want to really talk about a little closer, is age. So as we grow older or as we develop throughout life, the skin changes. So a few things I'm going to stress here. Collagen is lost. When you lose collagen, you develop wrinkles. The dermal layer of the skin becomes thinner, putting you at a higher risk for skin tear from shearing and friction kind of motions. Then we start to lose the function of our sweat glands and subcutaneous sweat glands and sebaceous glands. So when that happens, your skin becomes drier. And then as we age, we lose our subcutaneous layer. So thermoregulation becomes a problem. So causes of all skin alterations, we can look at newborns and infants. The first 2 weeks of life, the skin is not matured yet. It takes those first 2 weeks of exposure to the air to help the skin mature fully in a newborn. And during that time, their skin's permeability is very, very high. So they can absorb tons and large amounts of volume can go through their skin in those 2 weeks. So we have to be careful what we put on those babies' skin. And then as we grow older, like I described, the skin becomes thinner and more fragile. It loses its elasticity and other things, like I previously described. Chronic illness, we already mentioned that, and the use of some drugs like corticosteroids, oral or topical. Medications can increase sensitivity to sunlight is another thing. Certain drugs that we use to treat, for example, rheumatoid arthritis or even cancers can do that. Other drugs, certain antibiotics also make you more photosensitive to light. So example would be doxycycline, makes you more sensitive to sunlight, and tetracycline. So who do we assess? When, how, and what do we assess exactly? Who do we assess? Or who does the assessment? The assessment is always done by the nurse. Remember, assessment is not a task that can be delegated to anybody else. The nurse is responsible for the assessment. And the best time to do those assessments of the skin involve times when you are maybe doing AM care, doing your physical exam, when you're turning or repositioning a patient, when you're having to clean somebody who's maybe been incontinent. Those are examples of times to assess the skin. Important thing to point out here for assessment, if you cannot see the skin, you did not assess it. So if there are things on the person's body that needs to be removed to properly observe the skin, then you have to remove that item off the skin, or you can't see it. And we'll look at examples of when that didn't happen and what can result later on. What do we observe? We look at the color, distribution of any marks on the skin, like molds, lesions, scars, things like that. Presence of edema, presence of any breakdowns, skin turgor, tattoos, piercings, any lesions that are on their body. And, of course, odor. If there's any odor, we would make note of that. So, as far as the color of the skin, an example of why it's important to note the color. Color indicates amount of perfusion or circulation. So, if the skin looks pale, you may deduce that there may be a circulatory problem in that area of the body where that skin is. Redness, swelling, pain, rashes, inflammation, infection, burns, that all could be indicated by the color of the skin. So, lesions. The lesions, as you go along in the program, you'll learn more about different types of lesions. For example, if we note nodules on the body, you want to describe those nodules. You want to describe them because the appearance of that nodule may indicate a certain type of pathology going on in the skin. For instance, to indicate squamous cell carcinoma, you may see a nodule with edges that are not symmetrical, with a ulcer in the center. That may indicate a type of squamous cell carcinoma. Or if you have another lesion that looks dark, that's asymmetrical, the colors within it are not the same, that it's multicolored, with those irregular edges, that may indicate a malignant melanoma, for example. So another example would be a red ring that may be ringworm. So describing the appearance of the lesion is real important. Okay, as we go along, let's see. We are going to start looking at other detailed things to assess with. And one of the tools that you're going to use to assess patients' integumentary system involves the Braden scale. The Braden scale is simply a researched risk assessment tool, and it is used to define actual or impending tissue integrity problems. It's used because it provides structure and a consistent approach to assessing for risk for problem with integrity of the skin. So it helps you identify patients who are at risk, basically, or possibly could be at risk, potentially. Some of those risk factors I'm going to list right now. Those people who are immobile, incontinent, malnourished, decreased sensitivities to sensation or a decreased level of consciousness, general debility, malnourished looking people, exposure to friction and shear, age, smokers, any condition that would cause chronic pain might be putting them at risk, or perfusion problems. Prolonged surgery, for example, might be a risk factor for this. Hypotension, another risk factor. So what does the Brady scale look at? It looks at sensation, perception, moisture, activity, mobility, nutrition, and friction and shear. Those are the areas or the concepts that are assessed that will define someone who is at risk. The important thing to note is how does it score. So the maximum score a patient can receive is 23 points. Anyone who falls between 15 and 18 is at low risk for a breakdown. If they fall between 13 and 14, they are at moderate risk for a breakdown. And if they are between 10 and 12 or less, they are at high risk for a breakdown. So as you notice, the lower they score, the higher their risk for a breakdown. When we look at wounds, we want to describe the discharge that is coming from that wound. And we have general terms such as serous, serous sanguinis, or purulent. So serous is defined as a clear, watery, plasma-like discharge. Sanguinis is a red discharge, and it indicates some type of bleeding going on in that wound. Purulent indicates that there may be a causative agent or an infection going on in that wound. And purulent can look thick. Most of the time it's thick, yellow, green, brown, black kind of discharge. Usually has an odor, and depending on the bacteria that's in the wound, it will produce a specific type of scent. And you'll learn that the more you get exposed to them. So when we're describing our wounds in our documentation, we will use these terms, and you will combine them if you see a combination of them. So serosanguinous means a pink pale drainage with some redness maybe in the fluid. Purosanguinous indicates pus, purulent drainage, and with bleeding going on, so it'll look like there's blood also in the drainage. Some of the things that we assess as well when we look at assessment is lab data. So we're going to look at the blood count. The blood count, we pay attention to their white blood cells, their red blood cells, plasma, and coagulation studies. A white blood count that is low is just as bad as a white count that's elevated. A low white blood count indicates that there's a poor healing that's going on, because probably not getting enough perfusion to that area, for one thing. Red blood cell count, a decreased hemoglobin. The hemoglobin is what attaches oxygen to the red blood cell, and that is circulated around the body. The cell will retract it from the heme part of that red blood cell. So when we have a decreased hemoglobin count, we have a problem with oxygen supply to the cells. Again, another indicator of poor wound healing. Prolonged coagulation times. Prolonged coagulation times means that it takes longer for the blood to form a clot for some reason. So there may be excessive bleeding going on as a result with that prolonged coagulation time. The coagulation factors that we measure in the blood, some of them, the primary ones, the common ones, involve the PT, or prothrombin, or the PTT, partial prothrombin time. So those two are the labs that you would look at to see what they're measuring the time at. So the opposite of that scenario can occur, where there is hypercoagulation. Hypercoagulation is just as bad as prolonged coagulation. So hypercoagulation means the blood is clotting really fast, really, really fast, faster than normal. And that can also indicate a problem with perfusion. So either way, it's an oxygen supply and demand problem with the cells. Serum albumin is also lab measured, and it's an indicator of protein source. We use it as an indicator of an overall nutrition level for our patients. So if the albumin level is low, then we can define that patient as malnourished. They would be placed at a high risk for infection in that case. And again, poor healing of the wound. We need adequate protein to rebuild cells in that case. Wound cultures. Sometimes you may have wound cultures ordered, and in that case, that would be a wound they suspect has an infection going on or a causative agent to culture out and treat. So you would collect a culture. In your textbook, it does outline the procedure for collecting a sterile wound culture. And the main point here, it is a sterile collection. Does not mean you have to be in a sterile gown with sterile gloves on necessarily. It just means that the device that's going to collect the culture needs to remain sterile. The container that's going to have the culture sample placed in it must remain sterile. And then you can send that off to the lab. Remember, nutrition and circulation and hydration, blood count, all reflect circulation. So it is a good indicator of whether your wound will heal properly or not when we look at these areas of assessment. So now we're going to look at pressure ulcers. Pressure ulcers are exactly what they sound. Pressure causing an ulcer formation in the skin. So pressure causes ischemia, and ischemia causes a lack of perfusion or a lack of blood supply to the cells where that pressure is applied. And as a result, the cells of the skin are deprived of oxygen, and they also are unable to remove waste products. So we have an accumulation of waste products in that area as well. And then the cells die. And that's what causes, simply saying, the pressure ulcer. We have a lot to go over with pressure ulcers, so I'm going to go a little quickly, but it's all written down there for you to follow along in the PowerPoint. So please refer to the PowerPoint and refer to your textbook also. So first, regulatory agencies I'm going to mention, because pressure ulcers are one of these factors that are never events. They should never occur. They are completely preventable in every population that we are going to see as a nurse. So for that reason, the regulatory agencies, Medicare, Medicaid, have decided, they have passed legislation stating that for certain pressure ulcers, hospitals will not get reimbursement for care if it develops in their facility under their watch. So, stage 3 and stage 4 ulcers are the type of pressure ulcers that are non-refundable if a patient develops it while they're under the care of a hospital system. So I'm going to define for you right now what is a pressure ulcer. So there's two things we need to compare. What is hyperemia and then comparing that to pressure ulcer. Hyperemia. Hyperemia is a redness that occurs that's blanchable. You blanch the skin and redness goes away within an hour. So less than an hour's time, the skin will return to its normal state. If it looks real red and you blanch it and it doesn't blanch right away and you come back and you keep checking it and eventually within that first hour it starts blanching and returning back to its normal state, then that's the definition of hyperemia. Hyperemia is just a vasodilation that occurs for some reason in an area of the skin and it stays red. So we blanch it to see if it's going to blanch, and you keep blanching it until you see it start blanching. And that's an indication that perfusion is finally returning to that area of the skin. A pressure ulcer is different. It's an area of redness on the skin that when we blanch it, it doesn't blanch. It remains red. It never returned back to its normal state of blanching and then, returning back to its normal state. So an area of redness that you can blanch and is non-blanchable for greater than 2 hours is considered a pressure ulcer. So the time it takes for perfusion to become detrimentally impaired is 2 hours. So if pressure is applied and it stays applied, impairing perfusion for 2 hours or more, then you most likely will have damage to that area for perfusion and circulation. And that is where the 2 hours comes from. Okay, so the risk factors for a pressure ulcer. I already went over that, so I'm just mentioning it real quick again. Risk factors involve shearing and friction, immobility and pressure, inadequate nutrition, incontinence, mental status that's decreased, diminished sensation in the body, excessive body heat, advanced age, and any chronic medical conditions. So when we assess for a pressure ulcer, it's, like I said, it's a non-blanchable area that lasts greater than 2 hours or greater. But it also, we have to pay attention to the area where this is occurring at. If the area is located over a bony prominence, then we can define it as a pressure ulcer. So pressure ulcers develop over bony prominences of the body, and there are specific areas that are mapped out, and I'll show you a map in a few minutes. So we look at the location for assessment of a pressure ulcer. We also look at the measurements of the ulcer. You measure the longest width times the longest, you measure the longest length times the longest width times the depth of the ulcer. You're going to look at the color and describe the color like we talked about, and then we're going to stage pressure ulcers. We will describe the wound margins, and then we will also describe the skin surrounding the ulcer. We will look for signs and symptoms of infection as well. So the color we already talked about. Staging, I'm going to define the stages of pressure ulcers for you in a few minutes. The condition of the wound margins are important to note. The wound margins are the edges of the wound. What does it look like? Does it look flat? Does it look raised? Does it look rolled? Those are important descriptions about the wound that can indicate whether the wound is healing or it's not healing. The integrity of the surrounding skin, also called the peri-wound. So the peri-wound is the skin surrounding the wound, the healthy skin surrounding the wound. It's important to make note of the healthy skin. It could be red, it could be inflamed, it could be edematous, it could be moist and wet. So all these things need to be looked at and observed and documented. Signs and symptoms of infection, the acronym HYPER is used. So you want to look for heat, induration, pain, edema, and redness. Just to make sure y'all understand what induration means. Induration is not edema. Induration is a little worse than edema. It's an area of hardening in the soft tissue. It's not as hard as bone or stone, but it's an area of hardness, firmness that's in the tissue. And it's, just important to note. So here is the map of the bony prominences of the body that we will describe as part of the definition of a pressure ulcer. So the forehead, the nose, the chin, the ear lobes, the occipital bone on the back of the head, the shoulders, the scapulae in the back, the sacrum on the lower back, your hips, your knees, your heels. Those are the main areas for pressure ulcers to form. So again, the definition of a pressure ulcer is the location of the ulcer along a bony prominence with a non-blanchable area of redness, or we will stage the wound if it's stageable. There are along a bony prominence. Okay, so next we're going to look at prevention of pressure ulcers, because like we said earlier, pressure ulcers are preventable. They are considered never events. So in order to prevent a pressure ulcer, you have to promote proper nutrition, of course, skin hygiene, avoid trauma to the skin, and provide the proper support or support device for the patient to be on. So those patients who are at risk, we need to consider all these areas for prevention. So first, proper nutrition. Proper nutrition involves a high protein diet that's rich with vitamin A, B, and D, zinc and iron minerals, proper hydration, and then we want to assess the patient's weight. So we want them to be their ideal body weight, and we want to also assess their albumin levels. Their albumin level should be 3.5 or I think 3.5 to 5, whichever your lab defines as the norm for albumin. So we want to pay attention to the amount of food the patient's eating with each meal. We want to promote at least 50% of that meal being consumed and tolerated. You want to assess their level of albumin. We want it to be at least within the normal range for our normal albumin level for that patient. You want them to, if they're underweight, you want to promote weight gain. If they're overweight, then we want to promote weight loss somehow. Proper hydration involves at least 2 liters of water a day, unless their fluid intake is contraindicated depending on their comorbidity. All right, so maintaining proper skin hygiene. Proper skin hygiene involves cleaning the skin daily and making sure that it's dry. So when we clean the skin, you want to use minimal friction. You don't want to be aggressive when you're washing them. You want to use mild soap agents to clean the skin. You want to avoid hot water. You want to avoid alcohol containing lotions when we moisturize the skin. And the use of diapers should be avoided. Diapers can be used on certain people. The people who should use diapers are those who are mobile. The mobile patients can get up and clean themselves, change their diaper if they need to and whenever. The patients who are immobile are unable to get up, are unable to change those diapers, and tend to sit in wet or dirty diapers for prolonged periods of time. that puts them at a greater risk of developing a breakdown in the skin. So those patients should not use diapers. And again, avoid alcohol-based creams. You want alcohol-free creams when we moisturize them. Inspect the skin daily, especially looking at the bony prominences of the body, as I defined. And if you do see an area of redness, you should never massage those areas. I know you're tempted to massage them, but that's only applying more pressure in the area that's already been impaired because of pressure. Avoid hot water, mild soap and friction, and limit the use of diapers. So if we look at avoiding skin trauma, people who are at greatest risk for trauma to the skin are those patients who are not able to get up on their own, or are not able to move about in the bed on their own. And in that case, we would want to keep their heads, the head of the bed, elevated no more than 30 degrees, and that avoids them from sliding down the bed and causing a shearing and friction damage to the surface underneath them. Sheets can become a source of pressure if there are wrinkles in the sheets underlying the patient. So you want to make sure that the sheets that they lie on are wrinkle-free. And use proper skin barriers. We have skin barriers like lotions and wipes that we can put on the skin as needed. For patients, for example, that are incontinent or who have very wet, draining wounds, we would use a skin barrier to protect the peri-wound and ensure that that healthy skin remains healthy. When we consider positioning a patient, patients who cannot move themselves need to be moved at least every 2 hours. And now you should understand why. Because the definition of a pressure ulcer example, it takes about 2 hours for pressure to cause an impairment to the circulation in that area where the pressure is applied. So the idea is within 2 hours that patient needs to move so that this is not going to occur. So every 2 hours minimally. They should be turned more than every 2 hours. Okay. If we look at supportive surfaces now. Supportive surfaces involve things like overlay mattresses. There are foam mattresses, there are air mattress overlays that we will see used. And what these surfaces do, all of them do, is to redistribute the pressure underneath the patient, the area that the patient's going to lie on or sit on. So if you assess someone with the Braden scale who requires a moderate to high risk for a breakdown, they will probably qualify for an overlay mattress of some kind. In some cases, they may require a specialty bed in that circumstance if it's a high probability from the Braden scale assessment. So we have things like alternating air mattresses, high-low air loss mattresses. We also want to consider protecting the heels. Heels of every single patient in the hospital should be considered. I don't care if they are a low risk for skin breakdown. The heel is an area that is high incident rate of breakdowns in patients. And for me, as an example, I'll give you. I was hospitalized with a condition. They didn't know what was wrong with me at first, and they were giving me a lot of pain medicine that was knocking me out. I'm very sensitive anyway to medicine, so it didn't take much. I was probably unconscious for almost a week till they figured out what was wrong. And when I did fully come awake and aware of what was going on around me, my heels were the first thing I noticed. My heels were on fire, dying pain. And when I looked at them, they were red, 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 because my heels were never lifted off the bed mattress. So just from me lying in bed, not moving enough because I was unconscious due to drugs given to me in a hospital, my heels became impaired, and you could probably have defined it as a stage 1 pressure ulcer on my heels back then. So you have to lift patients' heels and make sure you're checking for that area on every patient. Okay, so now it's time to look at staging pressure ulcers. So pressure ulcers can be staged from stage 1 to stage 4. Now, you have to be careful about what you're staging. We stage pressure ulcers. We do not stage just any wound on the patient. So as I defined, a pressure ulcer has to be an area of redness that is non-blanchable for greater than 2 hours and is located on a bony prominence. That is our definition of a pressure ulcer. So stage 1. Stage 1 is a non-blanchable erythema of intact skin. Stage 2 is partial thickness skin loss. Stage 3 is a full thickness skin loss. But it does not involve the fascia. It goes into the subcutaneous layer only. Stage 4 is a full thickness skin loss that goes below the fascia, involves the fascia, muscle, and bone layers. And then we have unstageable pressure ulcers. Those are pressure ulcers where we cannot see the wound bed to determine the depth of involvement of that wound. So it's unstageable in that sense. All right, here are examples of pressure ulcers that involve the heel. And in this example, you can see the heel was in a device that was made to protect it, and it actually ended up causing the breakdown. Why? Because they did not assess the wound. They did not assess the skin properly. They probably never removed the device to look under there and see, is the skin intact, red, what's going on? So this person developed a bad staged pressure ulcer. The next slide is an example of stage 1 erythema that does not go away when you blanch the skin. Stage 1. Next slide you can see involves stage 2 pressure ulcer. In stage 2 pressure ulcers, you can see the epidermis layer is involved and the dermis layer is involved. It forms a small crater, abrasions, or a blister are examples of different stage 2 ulcers. The next example is a stage 3 pressure ulcer. Stage 3 pressure ulcers involve the subcutaneous layer and may extend to the fascia. It does not involve muscle. It does form a large crater and may involve what we call undermining. Undermining is when you look at the edges of the wound, you'll see gaps of tissue under those edges, and that's the degree of undermining that you'll measure. So stage 4 involves all the layers of the skin and the underlying tissues. So it goes through and through the dermal layer, subcutaneous layer, into the muscle, and then again into the bone, if it's all the way through to the end. If it involves the bone or muscle, in that fact. The worst type of problem that you will find with the stage 4 pressure ulcer is osteomyelitis. So often they will rule out osteomyelitis and sometimes treat the patient empirically until they know for sure that it's not osteomyelitis in the wound, in the bone. All right, so interventions now for our pressure ulcers. So the main thing for stage 1 pressure ulcers involves cleaning the area and applying a skin barrier. Skin barriers like A&D ointment, aloe vera, aloe vesta lotions. There are different types of skin barriers on the market that you can use to protect the skin, the healthy skin around the wound and the wound itself. Sometimes we'll see dressings used, and those are usually transparent film dressings. Make sure if you're putting up transparent film dressing that is a permeable film dressing. You don't want to put an occlusive dressing on a stage 1 ulcer. So permeable means the air can pass through, in and out of that dressing. Okay. And then the main thing is to avoid pressure on that wound. Reposition that patient frequently. Apply the right surface device to help redistribute pressure underneath the patient's body. And often those are the patients who you'll see the low air loss mattresses used, overlays that will be placed on top of the bed mattresses to help do that function, redistribute the pressure. Stage 2, we want to clean the area, also protect the wound with a dressing, because this is an open wound now that we will have to deal with. So often we will use hydrocolloid dressings for these patients, and I'm going to send you some examples of these dressings on a file later. So to stage 2, we have to protect the skin, protect the wound. So clean and protection, primary functions of care with a stage 2. Repositioning the patient and also considering pain control. These wounds are very painful, stage 2 wounds. So we want to avoid infection by cleaning and protecting the wound, repositioning them, prevent any further breakdown, and promote circulation return, and then apply care for pain measures. Stage 3 pressure ulcers are the deeper, full thickness wounds, and they tend to be very wet producing wounds. They drain a lot. So we will use dressings that are going to be very absorptive dressings. And examples here are alginates and hydrogels. So an alginate is like a cotton-looking substance that will fit inside the deep crater wound and fill in the dead space. It's important to do that because if you leave dead space available in a wound, an abscess will just form and the wound will become worse. So we have to fill in that space with something. So an alginate is perfect for that. It fills in the dead space and it absorbs a lot of volume. It absorbs 20 times the volume in weight, an alginate. Hydrogels do a similar thing. Hydrogels also are good to help what we call debride the wound. It will break down the dead tissue. It promotes the immune system to do that, and it also fills in the dead space. So it forms two functions in that case. And the last thing, it's an open wound again. So we want to make sure it stays clean. We want to make sure we're assessing for signs and symptoms of infection and protecting the wound. So with stage 3, I mentioned debridement. Often these wounds will need debridement. They're bigger, deeper wounds. They produce a lot of discharge, and the discharge collects at the surface of the wound usually, and it might look yellow. If it's yellow and crusty looking, we call that sloughing. It's just debris, dead tissue, dead cells. And then sometimes those dead cells will become hardened, and that's also dead tissue and dead cells that were pushed out or moved from the wound. And we need to debride all that. We need to remove it so the wound can produce healthy cells. If those cells, those dead cells, are not removed, it won't allow new cells, healthy cells, to regenerate. So we want to promote granulation by removing all that dead tissue in this case. So with stage 4 wounds, we're going to do similar things. These are very, very deep wounds. In some cases, the debridement is going to involve going to surgery or using similar substances that we use for stage 3 wounds. We also definitely going to consider the surface the patient's sitting on or laying on, so we want to make sure that that's a proper type of surface to redistribute pressure for that patient. In some cases, you'll see air fluidized beds. Those are beds that have fluid that gets circulated from place to place to mimic movement underneath the patient. It doesn't mean you don't have to turn them still, but it helps to prevent pressure from developing and redistributing the pressure underneath the patient. So debridement, in this case, we call it Sharp's debridement. And there are two different types of Sharp's debridement. There's surgical Sharp's debridement, and then there's bedside Sharp's debridement. So surgery involves a surgeon. They go to surgery, and aseptically it's done. They come back, they have a pretty dressing when they come back from surgery. At the bedside, a certified wound care nurse usually is the one who's debriding the patient with a scalpel. And we'll do that at the bedside. Just cut away the dead tissue, remove the sloughing, remove the necrotic tissue from the wound bed so that it will start to heal and produce granulation tissue. So in these cases, the stage 4, you looking for signs of undermining and what we call tunneling or sinus tracts that can form in these wounds. So you're also looking for complications of infection, the worst one being osteomyelitis if it involves the bone. Unfortunately, most of them do. Okay, so the purpose of our dressing is to protect the wound from mechanical injury, protect the wound from microbial invasion, provide a moist healing environment, provide thermal insulation, absorb drainage, remove the dead tissue by debriding it, and prevent bleeding or hemorrhaging, and splint and support the wound. So our pressure ulcers, we will choose our dressing depending on the type of ulcer we have and the assessment that we find with the wound. So we will look at the location, the size and the type, the amount of exudate, the need for debridement or not, and if there's an infection present or not. These things will determine what type of dressing we will use. Many types of dressings are available in the market. There are transparent film, hydrocolloids, hydrogels, alginates. All of these types of dressings can be impregnated with antimicrobial substances like silver and gold. There are newer things that are being used today now also. So lots of different choices. So I have the next few slides are going to go over the types of dressings to use with what type of ulcer in general. So we already mentioned that transparent dressings are used on stage 1 wounds because they protect the wound. They have to be semi-permeable to allow oxygen in and out of the wound, and it protects them from shearing and friction damage as well as bacterial invasion. So hydrocolloid dressings are typically used for stage 2, stage 3, or stage 4 wounds. They can stay on for several days at a time, up to 10 days usually. and they will absorb exudate from the wound and provide a moist, warm environment to produce granulation tissue development and removal of the exudate. So you want to assess for, again, contamination, signs and symptoms of infection. So the wound protects the dressing protects the wound from bacterial invasion and from damage from shear and friction. One extra thing that a hydrocolloid dressing does, which is not so much needed for stage 2, but stage 3 and 4 wounds might require debridement. So depending on the wound condition, if it needs debridement, that may determine what type of dressing you're going to use. You may want to use a hydrogel in some cases if you need to debride the wound, a large wound. Some cases you may use a hydrocolloid that will do a similar thing. It just will take a little longer in that case to help debridement occur. Hydrogels then are they're glycerin or water-based solutions that you squeeze, you put inside the wound, and it requires a top dressing to be applied on the wound to hold it in place. So we want to use things that are non-adhesive to our wounds so that we don't damage the healthy tissue around the wound, the peri-wound skin, the healthy skin. We don't want to cause a problem with healthy skin because of tape or adhesives that may rip off that layer of healthy skin when we're changing the dressings, right? So always consider using a non-adhesive dressing to put on top of a hydrogel. Hydrogels, again, are used often to help debride a wound. So wounds that are necrotic, have sloughing, we'll consider using hydrogels. They are good for stage 3 and 4 wounds because they fill in the dead space and protect the wound. So the last type, again, is alginates. The alginates are that cotton-looking dressing. They come in different forms. They come in sheets, they come in ropes, they come in rolls. This is an example of a roll. They're non-adherent sheets of a dressing. They even come in the form of powders. I didn't say that. Or beads. I've seen beads being used. They're very, very absorptive. So it absorbs 20 times the weight of in exudate volume. So they're very good for wet wounds. Stage 3 and 4 wounds are going to produce a lot of drainage. They do require a secondary dressing, a dressing that goes on top of them. It eliminates the dead space and removes the debris, providing a warm, moist environment for the wound to heal and produce granulation tissue. Okay, so we're coming to the end of pressure ulcers. The dressing review here. Avoid transparent film on fragile skin. Do not use use hydrocolloid dressings on fragile skin and non-infected wounds. Hydrogels are often used for wounds that have a lot of sloughing or necrotic tissue. So it helps to debride that tissue away. A new term I didn't define yet, but autolytics. An example of an autolytic is a hydrocolloid dressing. Autolytics promote debridement by self-digestion with enzymes. So the immune system is what causes autolytic debridement. So we put on a dressing and we allow the body's own immune system to come in and remove that debris from the wound bed. It takes a very, very long time. It's a slow process. Those are usually wounds that don't have a well supply of perfusion to the wound. That we will do autolytic debridement. So autolytics are thin films, alginates, hydrocolloids, and hydrogels that are used. Honey is another form of a autolytic type dressing that we would use, or therapy we would use. And honey, I didn't mention before, but honey is also used because it is a natural antimicrobial. And what I mean is there's a form of medical honey that we would use. It's not just over-the-counter store-bought honey I'm talking about. So this is a medical honey that is specially produced by bees and harvested for wound care that we use. Okay, so let's move on. We're going to go on to other types of wounds. Other types of wounds. Lacerations, incisions, abrasions, contusions, punctures, and penetrating wounds. So a laceration is just a torn area of tissue that often happens from accidents. Machinery accidents, where the wound is dirty, has a jagged edge, and accidental. Sharp incision wounds are purposeful wounds. Those are our clean wounds. Those are wounds made with a scalpel, usually, or a knife of some kind. Abrasions or surface scrapes, usually unintentional, but sometimes can be planned, like when you go to the dermatologist and they do an abrasion therapy to remove the top layer of your skin, whatever. So dermal abrasions can be considered an abrasion. That's a purposeful wound, though. Those are open wounds. Contusion. Contusions are closed wounds that happen from a blunt instrument impacting the tissue area. So those will disrupt the blood vessels in the area and then lining the skin and cause bruising or ecchymosis to develop. A puncture wound is going to occur from penetration into the skin from some kind of sharp instrument. And then a penetrating wound is definitely a sharp instrument that's usually unintentionally puncturing the skin, and it's an open wound usually. So we classify these wounds a few different ways. They're intentional, and you heard me say that term already, intentional or unintentional. Or they can be classified as open or closed, like you've heard me say. They can also be classified as acute or chronic. And then also by depth. So 4 different ways to classify these wounds. So the unintentional and intentional, they're pretty self-explanatory. Either it was on purpose or it was not purposely done. Open, it's a break in the skin or the mucous membranes. Closed, it's a underlying tissue damage that occurs. The skin is not broken, but the tissue underneath the skin becomes damaged. Then acute versus chronic. For it to be acute, it needs to have happened within the first 2 weeks. And then after that, it becomes chronic. So wound depth is defined as superficial, involving just the epidermis, the top layer of the skin. Partial thickness, which involves the dermis layer of the skin. And then we have full thickness, which involves the muscle and bone areas of the skin. So all the way through to the bottom tissues is a full thickness wound. Penetrating wounds can be at any depth. It could be superficial, it could be partial thickness or full thickness area wound. Okay, so unintentional wounds are usually seen shortly after they occur. Those are those accidents that happen unexpectedly. So the first aid for an unintentional wound is to control the bleeding, prevent infection, control the pain and swelling, and then assess the depth of the wound, the quality of the wound, and the type of wound that you have. So with cleaning the wound, you're going to clean it with a sterile normal saline and then cover it with a clean sterile dressing. If bleeding's occurring, then you want to apply firm pressure to stop the bleeding. You want to assess the edges of the wound, and then we will try to determine the depth of the wound. You can apply ice to help control the swelling, and it also controls pain level. If it's on an extremity, then you want to elevate the extremity to help reduce swelling. So when we look at appearance, we're going to look for signs and symptoms of infection and the type of drainage, if there's any drainage going on. So again, signs and symptoms of infection involve heat, induration, pain, and edema and redness. There is a slide that goes over different examples of different types of tissue damage, wounds. Abrasion to the leg, ecchymosis, which is a contusion to the leg, or ecchymosis around the eye, like a black eye. There's a penetrating wound in somebody's back with a sharp knife. And then there's a partial thickness wound of a foot, and then a full thickness wound of an ankle. All right. There is also on the next slide a picture of our depths, and it just demonstrates the different depths of these wounds. So the superficial wound involves just the epidermis. Then a partial thickness goes down into the dermal layer of the skin. A full thickness wound then is considered everything else below the skin. So full thickness wound is when you see the subcutaneous layer of the tissue. If you see muscle or bone, those are definitely full thickness wounds. So a little different from looking at pressure ulcers. So when we look at measurements of a wound, it's the same thing. You want to measure the longest length times the longest width times the depth. The next slide is going to show you a comparison of wound classification and then comparing that to pressure ulcer staging. If we go on, when we look at color classification of a wound, that's talking about the actual color of the wound. Is it red? Is it yellow? Is it black? Or is it mixed? Is there a mix of yellow, red, and black? Red indicates tissue repair, granulation tissue. And we want to see that red, beefy color granulation tissue in the wound bed. And it actually looks like a steak. If you look at a steak, and maybe you'll never think of a steak in the same way, but granulation tissue is that beefy red tissue, cells. That's brand new baby cells coming up from the wound bed. And that's a good sign. If there's dead space in that wound, you need to do the same thing as we talked about with pressure ulcers. You have to fill in the dead space. If you leave dead space available in that wound bed, it's going to develop ulceration, and maybe tunneling or undermining might present itself from that dead space being there. So you need to fill in the dead space. So again, we would use a hydrogel, alginate of some kind to fill in that dead space, and then cover it with a dressing. Sometimes that top dressing is a transparent dressing. Remember, it has to be permeable to oxygen. Or it's a hydrocolloid dressing to cover it. The yellow color is characterized by the same thing as we discussed with pressure ulcers. It's just some dead skin that's left in the wound bed, and it looks yellow. It's a little soft. It might get crusty at some point. It's dead tissue that needs to be removed. So it needs to be removed in order to promote granulation from occurring, which is what we want in the wound bed. So most of the time, we can do that by just using normal saline to clean the wound bed with soft friction, not firm friction in the wound bed, but just wiping it out with this normal saline, or irrigating the wound with normal saline. And I'll show you different methods to irrigate wounds to help remove that dead tissue. Then you would put in, again, something to fill in the dead space if there's dead space to fill in, depending on the depth of the wound, right? An alginate or hydrogel again. If there's a causative agent that's been cultured out, then we would probably use some type of antimicrobial dressing to put on the wound bed itself also. Then black color. Black color, we need to remove that tissue. If you don't remove that tissue, it most likely will result in a non-healing wound. So debridement is required with black debris in the wound bed, so that viable tissue can be seen, and then if need be, we can stage it, or it will just produce granulation tissue. So in this case, we treat the worst color first. We treat the black debris by debriding it out. Then if it's yellow debris, we're going to clean it. Make sure we clean that wound bed really well. Remove that sloughing as much as we can. And then for red wounds, we want to just maintain clean, moist environments to take care of that wound that's healing. We want to promote the red, beefy granulation tissue to continue. So different ways to debride a wound. If we need to debride a wound, so black, we said, colored wound, we need debridement. So surgical debridement, send them to surgery. Mechanical debridement, that's Sharp's debridement at the bedside, or it might involve irrigation of the wound. And then there's enzymatic debridement and autolytic debridement. We've kind of talked about a little bit of each of those. There is next some slides that show you different images outlining what's necrotic tissue look like, what does epithelial edges look like that are significant, and some granulation tissue. So on slide 53, which is the one I'm on looking at, the edge of this wound is white. It's white, and that's significant to note when you documenting the appearance of this wound. The peri wound and edge looks a little white. May indicate a problem with perfusion. It may indicate a problem with moisture. You know, when your skin is wet and you have a cut, maybe it's a small cut on your hand or something, and you've had your arm soaking in the bathtub for too long. When you look at it out the water, it may look a little white around the edge of that wound. Well, that's what this is. If it remains moist from debris, from discharge, the edges of the wound can turn white like that. And that is just an indication of some enzymatic damage going on the peri wound. of the edge of that wound. So you need to protect the edge, protect the peri-wound better. They do, in this picture, it shows you what granulation tissue should look like, and necrotic tissue, the black tissue. It's hard black tissue in the middle of that wound. So how are we going to debride this wound? Okay, so surgical Sharps debridement, they go to surgery. Sharps debridement at the bedside, wound care nurse will take a scalpel and will cut away the dead tissue from that wound bed. Chemical debridement involves applying a chemical onto the wound bed that will break down the dead tissue. These are enzymatic agents that are used, and they only, I guess, can't think of a word, attack the dead tissue. It won't break down healthy skin, in other words. And that's why we use this type of agent. And it's the only one on the market, and it's called Santyl. Is a trade name that you'll see, or you'll read the doctor's write. Santyl, apply to wound, however he wants it used. Autolytic debridement involves applying a dressing to the wound, and the dressing is left on, up to 7 to 10 days, and then it's changed out. The nurse will reassess the wound and see if we need to continue the autolytic dressings or not. The mechanical debridement involves using water. And we used to do this with these giant water pick machines. And I don't know if you'll see them around anymore. But we gown up, put the goggles on, the headpiece, everything, and then we go in there like space cadets and load the machine with the solution that we were going to use to debride the patient. It usually was some type of Dakin solution, which is a chlorine bleach solution, basically. 10% bleach solution or greater, depending on what they ordered. And we would spray it with a gun, pistol gun, and into the wound bed. Now this example shows you that same process with a syringe and a 19 gauge needle, and it's the same thing. It's applying a PSI of 8 to the wound bed to help break down the debris and mechanically remove it with pressure. Okay, so we're almost at the end here. The debridement of a heel is often not done. It depends on the wound. If the wound bed has an adequate blood supply, then it's safe to debride the wound, to remove that eschar. The eschar, in some cases, acts as a protective coating to the wound bed so that nothing from the environment can come in and cause an infection. So if the wound does not have an adequate blood supply, you will not see debridement of that wound being ordered, and that's why. There's not an adequate supply of blood to produce healthy cells in place of the dead tissue. They're going to remain. They're going to leave that dead tissue in place to protect the wound. All right. So, nursing interventions to treat infections. The main thing is to clean the wound thoroughly. Irrigate it with saline. We want to get a wound culture if needed. If they think it's infected, we're going to culture it. And then substances that are ordered usually are antibiotic powders and ointments. And I mentioned silver before. Gold is another antimicrobial agent that is often used in wounds that are infected. We never clean with betadine or hydrogen peroxide. Those are toxic to healthy cells. So if we have new cells growing in the wound and we use these substances to clean it, we're destroying the new cells. We're defeating our purpose, in other words. So we don't use those items to clean wounds. The next few pages are just pictures for you to look at. A wound vac is one of the devices you'll see patients have to help promote healing of a chronic wound. These are patients who have chronic wounds that are not healing properly otherwise. So they'll use these wound vacs, and the wound vac has a sponge that is placed on the wound bed. There are two types of sponges, black and white sponges, depending on the wound and the purpose of the wound vac use. They're going to pick the type of sponge to use in the therapy. Most commonly, it's the black sponges that you'll see. Someone who's trained to apply the dressing will do this. Not just anyone will apply the dressing. It is a sterile dressing application, or it's clean, but we say sterile application, but the skin is not clean, is not sterile. So clean technique is used when applying the wound dressing. Our purpose is, with these wound vacs, is to make sure it remains intact. So it produces a suction to the sponge that removes the dead tissue, sucks it away, and it's considered output. You're going to have a little container that you will look at and measure your output every shift that you work. And if the integrity of the dressing breaks, then the suction fails. So we have to either reinforce the dressing and get the integrity back in place so that the wound vac can start working properly, or we have to make sure someone else can reapply new dressing. The next one is examples of different drains that you'll see used with wounds. The common ones here are on this page. You have a Jackson Pratt, or it's also referred to as a grenade. And we also have a hemovac, which looks like an accordion kind of thing. And then we have Penrose drains. Those are they look like tourniquets, but they're a drain that's surgically placed in a wound by a doctor, and we will have a dressing over it, and we'll have to dress that wound as it needs. So all of these devices we have to maintain and support as nurses, and count our output if we're measuring amounts of drainage from them. The Jackson Pratt looks like a grenade ball, and it produces a suction when it's closed and intact. So you'll take the grenade ball that's inflated when it's not activated, and to activate it you have to compress it and close the top so that it's collapsed on itself. And when it's collapsed on itself, it's activated, it's actually draining by suction from the wound discharge. The hemovac is similar in that it looks like a disc with a spring inside, like an accordion, I said. And when it's opened up all the way, it's deactivated. So at that point, you need to empty it, measure your output, collapse it, and close the lid, and then it's activated again. Penrose drains are just drains like in this hand with a dressing wrapped around it, and you just need to maintain a clean dressing. You'll have to change the dressing as needed. So principles of wound healing involve intact skin is the first line of defense. Surgical asepsis is used when we do wound care. But remember, the skin is not a sterile organ. Just that the items that we use when we do wound care should be as clean as possible, sterile as we apply it to the skin. Adequate blood supply is essential for wound healing, and the wound must be free of foreign material for it to heal. including debris that's produced from the wound bed. The extent of damage and the person's state of health affect wound healing. So they have to have a positive attitude about this and want to help promote wound healing themselves. Adequate nutrition has to be maintained in order for new tissue to be reproduced in healing a wound. So factors that affect wound healing, it depends. Developmental age depends on how well or how quickly the wound will heal. We talked about that at the very beginning of the lecture. Circulation, oxygenation is essential elements that are needed for proper wound healing. Nutritional status does indicate how well a person's wound will heal. Lifestyle also plays a role in wound healing. So if they're obese, we need to take that as a factor that might impair wound healing. If they're a smoker, it will have an impact on circulation to the wound, because smoking actually just deprives the body of oxygen. That's what smoking does. And then regular exercise. Good circulation is promoted with activity. So lifestyle in that sense is important to consider. Medication and health status, overall health status. Medications and lots of drugs we talked about will impair the functions of the skin. So consider that. Aspirin, for example, interferes with clotting. Steroids interferes with the immune system. Anti-neoplastics also interfere with the immune system. So lots of things that can interfere with wound healing. The condition of the wound and then stress on the wound are two other factors to consider. So the condition of the wound means, is it dirty or clean? Is there an infection? What is the depth of the wound? Stress on the wound. Coughing, vomiting, getting in and out of bed, all may impact the amount of stress placed on the wound itself, depending on what part of the body the wound is at. Okay, so what this is leading into is, how do wounds heal, and what are some of the major complications of a wound? Types of wound healing: first intention, secondary intention, or tertiary intention. Those are the definitions of how a wound heals. So first intention is also called primary intention. That is when you go to surgery and the surgeon sutures you up. Or if you go to the emergency room, you have a laceration, they cleaned it out, and they sutured it up for you. You're healing from first intention. Secondary intention involves a wound that was closed, and for some reason, it opened up, or the edges were such that they could not properly be closed. So they weren't. So that is an example of a wound that would have to heal from second intention. Example of a wound that would heal through second intention would be a pressure ulcer. Pressure ulcers, you can't close the edges. The tissue dies. It's gone. You can't close what's not there, right? Let's see. The repair takes long in this type of healing. So a scar forms also, and the scarring is going to be greater than if you healed from first intention, for example. Granulation tissue has to form, so it's a longer process to heal in second intention. Tertiary intention, or third intention, is used when the wound is considered dirty or contaminated. So in some cases, a surgeon or physician will choose to leave the wound open. And that wound will stay open until they feel the wound is clean. And once it's clean, then they will come in and close it. Usually 3 to 5 days later, they'll come back and it'll be ready for them to close it. So that is the difference between the three forms of healing of a wound. Okay, so the next slide is going to just show you examples of first intention and second intention. So first intention, it's stapled or sutured closed, the edges. So that's your well approximated, intact suture line. Second intention is when the edges you're unable to close the edges for some reason. And so it has to remain open, and granulation tissue has to form, and then the wound heals over time. Long process. Okay. Third intention is, like I said, it's a dirty wound that's purposely left open, and once the wound is defined as clean, then the doctor, the practitioner will come in and close up the edges, and then the wound will heal. Major complications of a wound that's healing, trying to heal, are involved infection, hemorrhage, and wound disruption. So wound disruption, the two terms that you need to know are dehiscence and evisceration. Okay. So for infection that forms in a wound just delays the wound from healing. It doesn't stop it from healing, it delays it. If there's hemorrhaging going on, that's also a cause for delay in healing, but it can heal. That's when we will see drains being placed, and we will look at fluid being collected under the skin, and if the fluid collects enough, you'll be able to palpate the area of induration and detect the bleeding, hopefully. So those are examples of hemorrhaging from a wound. Wound dehiscence happens when a lot of stress is placed on that incision line. And enough stress occurs that it happens to pop open for some reason. So that's most likely going to happen in the first week once the wound is sutured. So within the first 5 days or so, if it's the highest likelihood of a dehiscence happens. So examples of that, causes of that, might be coughing, vomiting, diarrhea, just getting in and out of a chair could put enough stress on a suture line that it may pop open the sutures. So you call the doctor, you let them know, and they come in, they reassess it, they see if they're going to clean it and resuture it, or if they're going to let it heal by second intention at that point. The next one is evisceration. Evisceration is an emergency situation. And evisceration, the suture line pops open and the organs actually protrude out of the abdomen. People who are obese or malnourished have a lot of excessive coughing, vomiting, usually have problems with dehiscence or evisceration. Poor suture healing from chronic steroid use because they were a bad COPD patient, for example, could be the cause of this kind of complication. For both dehiscence or evisceration, if this occurs, you would apply sterile saline soaked gauze. That's, on a sterile gauze, of course, and then take that and apply it over the wound. Cover the wound. If there's bleeding, you want to control the bleeding and notify the physician emergently. So you would definitely have someone helping you in that situation. All right. Phases of inflammation. Phases of wound healing. So there are basically 3 phases I'm going to define. The first phase involves inflammation, the second phase is proliferation, and then maturation for the last phase. In the beginning of any injury, whether it's elective or unintentional, a wound for what we're talking about, inflammation is the first thing that you'll see happen. The body's defense mechanism, the immune system kicks in. So the inflammatory response occurs, and this will continue for at least 3 to 6 days. This is where phagocytosis is occurring. Hemostasis is the priority in this phase. So hemostasis control the bleeding. So platelet action stops the bleeding, clots form, fibrin is laid down, and then that's the beginning of our scar tissue that's taken place. So cellular repair is starting at that point. New blood vessels are now regenerating in the next stage, proliferation stage. The proliferation stage starts in about day 3, day 4, and lasts for almost a month. So proliferation is where, like I said, new blood vessels are starting to regenerate and reestablish perfusion to the damaged tissue that occurred. And in the proliferation phase is where we see granulation tissue occurring. That's what we call resurfacing of the wound bed. And we want to see what we call epithelialization, which is at the end of this. When we see epithelialization, that is the wound is healed. There's new skin now here. It's not just granulation tissue, it's skin now, we're calling it. The laying down of collagen that strengthens the skin and in the new area of the wound. Okay, remodeling is, or maturation is the last stage. And the last stage starts at about day 22, day 21, and this stage could last for 1, 2 years or longer. This is when the scar is laid down and the tissue becomes pigmented again, and we see the actual the skin looks like it's normal again in this stage. So the wound is essentially healed at this point. What happens is the skin develops a scar. The scar that's formed is now a temporary thing. It breaks down that scar and lays down more tissue, and it continues to develop scarring and then breaking it down and remodeling it till it starts to look more normal, more and more normal, till it's completely finished remodeling. Some wounds become chronic in the sense that the remodeling stage never completely finishes, and those are the wounds that we call chronic because it doesn't fully maturate for some reason. The important thing about knowing the stages of the wound healing, in general, what I just told you, that's kind of what happens in a brief summary. In the proliferation phase, if you do not have adequate nutrition, then you will not have the laying down of granulation tissue that you want to occur. So the resurfacing of granulation tissue doesn't take place properly if we don't have the proper amounts of protein, if we don't have the proper amounts of minerals, if we don't have adequate blood supply. Those factors are very, very important in affecting the proliferation phase of wound healing. Okay, so important about our nursing care then is also going to involve what to do to support our wound healing. Again, maintain a moist wound environment for the wound to heal. Wounds hate dry surfaces. Sufficient nutrition and hydration, prevent infection, and proper positioning. We want to promote circulation and prevent pressure from forming on the tissue. Psychological effects of a wound. There's pain involved, anxiety, fear, change in body image. So we need to consider all those factors when we are looking at our goals to set for our patient. So the goals then mean prevent injury, prevent complication, and promote healing. Okay. The process, nursing process for impaired skin integrity. So our nursing problem is going to be potential for or actual impaired skin integrity. We're going to assess the patient. So you would do that thorough physical assessment, which means more than just the physical, but we want to consider the high psychological aspects, the socio-psychological parts of assessment. When you interview the patient, you're going to assess their skin by just looking at them from head to toe. Look at the color, the degree of erythema, any redness, dryness, rashes, lesions, hypopigmentation areas. You want to inquire about any diseases, comorbidities, unusual bruising, problems with healing wounds. You want to know their history, the history about their skin, acute and chronic history, any treatments that they did that were ineffective. And then we want to also question them about their social life. We want to, look at their support, family support. What type of lifestyle do they live? Do they exercise regularly? Do they smoke? Do they do? Are they overweight? Are they underweight? Those kind of factors you want to question them about. The physical assessment would mean you want to assess the skin by observing and palpating the skin. Pay close attention to skin folds, like under the breasts, the groins, the elbows, behind the knees, the bony prominences. Observe for, you want to make sure you remove equipment that's on the skin so that you're assessing that area, like stockings, for example, socks, for example. Any diagnostic tests, cultures, all need to be reviewed. So when we look at defining independent interventions, then we're going to try and promote healthy lifestyles, prevent infection, and teach the patient about what type of soaps and lotions to use, the importance of keeping a moist, dry skin, the recognize signs and symptoms of poor circulation that would produce typical signs and symptoms of that, like the 5 Ps, pale, pain, pressure, paralysis. I forgot the last one. Anyway, signs and symptoms of dead skin, like necrotic tissue. What does that mean? Encourage exercise, a good diet. You're going to use collaborative interventions also. So we would work with our wound care nurse, our dietitians, our physical therapists, the dermatologist, the surgeon, whoever is the provider. So we work collaboratively with every team member to help correct any problems and prevent complications. Pharmacology therapy, you need to pay attention to the type of drugs that they're taking. And there are several drug classifications that directly affect the skin. Our chemotherapeutics, our drugs used for arthritic conditions, lung conditions, even the cardiovascular drugs can have an effect on our skin. And then consider the non-pharmacologic therapies like the wound vacs, a diet that's high in protein, high in vitamin D, E, zinc, and C. Those are good to help promote skin healing, and especially with patients who have chronic wounds, we need to consider those things. Okay, so nursing diagnosis that can apply to the integumentary system. Risk for pressure ulcer, risk for impaired skin integrity, impaired tissue integrity, risk for infection and acute pain. So this is the end of the lecture material. The rest of the lecture slides involve questions for review. So I'm going to quickly go through those slides right now, just to make sure y'all get the right answers for the questions that are on the rest of the slides. So this next slide is a question. Which of the following measures should be taken when the nurse observes additional bloody drainage on an abdominal wound that was initially dressed 7 hours ago? Notify the patient's physician of bleeding. Remove the dressing and assess the wound. Assess the patient for signs of shock. Reinforce the dressing externally. If you pick D, then you are correct. Which of the following statements best address the need to safely apply an enzyme debridement ointment? Enzyme ointment attach the dead tissue, so healing can occur. Place the ointment on a tongue blade and gently spread it on the wound. Apply the ointment. Be careful to avoid contact with surrounding tissue. Cover the wound with the gauze dressing and ensure contact with the ointment. C. If you picked C, then that was the correct answer. When changing a surgical dressing, the appropriate time to don gloves is after performing the initial hand hygiene, before removing the inner layer of a dressing, after removing the original dressing, before cleansing the wound with sterile water. C is the correct answer. Which of the following assessment findings is indicative of healthy wound healing? Absence of eschar, presence of slough, presence of granulation, small wound size compared with original wound. C, presence of granulation. Which serum albumin level would be interpreted as compromised status? Well, the normal albumin level, depending on your lab, ranges from 3 or 3.5 to 5. So the correct answer would be B in this case. Which of the following are primary risk factors for pressure ulcers? Select all that apply. Low protein diet, insomnia, lengthy surgical procedures, fever, sleeping on a waterbed. A, C, and D were correct. Okay, so the next slides are examples of staging pressure ulcers. The first one is an open wound, so it's not a stage 1. But is it a full thickness or partial thickness wound? This is a partial thickness wound, so it is considered a stage 2. This wound wounds, there's two, are covered with eschar. This is an example of what eschar looks like, eschar tissue. So we cannot see the wound bed at all to determine the depth of the wound. So this is considered an unstageable wound. Wounds that are 50% covered with debris or eschar are considered unstageable.